I'm a registered nurse and I own 5 small homes. I'm also the president of CALA. And today I have the pleasure of introducing Matthew from Interstate Restoration, who's one of our associate members. And we really appreciate everything that he is doing for CALA. And he's going to introduce our wonderful speakers today.
All right, well, thank you for that. And
so Matthew, I'll let you.
Take it away. Hi, everybody. I just want to say thank you for having me here today. Again, my name is Matthew Gahm, and I am a regional account manager with Interstate Restoration. We are an emergency response planning, mitigation, and reconstruction company. We are nationwide. We right now, I believe, are the second largest restoration company in the nation. We are global, and we've been in business about 70 years. So if and when you might experience any unfortunate emergency situations, such as fires, flood, smoke damage, water damage, biohazard cleanup, mold, asbestos cleanup, we are there to provide full service for any of the CALA members and the member communities. So it is my pleasure to help you guys introduce today's speakers. We'd like to welcome everybody to the vaccine workshop. The first speaker today is Dr. Gregory J. Gahm. Dr. Gahm is a geriatrician serving as the corporate medical director for Vivage, and medical director for several of Vivage's skilled nursing facilities. He attended the University of Colorado for undergraduate studies and medical school, followed by a residency in internal medicine in Arizona, a fellowship in administrative medicine and medical informatics at Harvard, and a sabbatical in clinical preventive medicine at Stanford. The second speaker that you will have today is Peter Myers. Peter Myers is currently the Residential Care Strike Team Branch Chief. He has worked with CDPHE for almost 13 years and was previously the Occurrence and Complaints Section Manager. Peter has a BS in gerontology from Towson University and worked in many different settings prior to his government services, including assisted living residences, nursing homes, and low-income senior housing. And now, please welcome Dr. Gahm.
Well, gosh, thank you. I didn't expect all that. I'd like to meet that guy. At any rate, my thought, I'm going to try to make this as casual as I can, but I think, at least from the way I work, and Tammy knows this because I worked with Tammy for years, the more people know and the more you're educated, the more you can answer your own questions. So what we're going to try, this isn't going to be exhaustive, but I'm going to try for about 20 minutes to give you an overview of what we know about the vaccine, the virus, and what we're doing with it. And so I'm going to start here sharing my screen and go through a presentation. Feel free to interrupt me, and a lot of questions will be answered before we end, but I'm hoping to make this really informal. Okay, so the first slide that I want to show, and forgive me if you already know all this information, I'll apologize in advance, but the more I talk to people, the more a lot of this is just people assume you know things that you don't. All right, so this picture that you luckily saw right behind my head, I keep everywhere and I dream about it, is of course the COVID virus. What I really want you to look at before we get into this is these little triangular orange things. They look really cute. They're called the spike protein. And so I want you to think of them as the fingerprint for the virus. This spike protein is only found on COVID. It is completely different than any other protein configuration, the way that it's laid out. And to some extent, from one COVID virus to the next, they're identical. The thing that will cause eventually this vaccine not to work is when there have been enough changes in this spike protein that your antibodies won't recognize it. So in its broadest sense, the way your immune system works is that you have antibodies, the little Y-shaped things you've seen, that come down and they actually recognize this and only this spike protein or something different on the influenza virus or a cancer cell, whatever it is they're trying to recognize. It's a lock and key, and this is the lock, and the antibodies are the key, and they're trying to fit exactly this picture. We know, for instance, jump a little bit ahead, the B117 variant in the spike protein segment of the genome had about 7 mutations. So this thing changed just a little bit. It appears that the vaccine still works against the variant and still close enough that it recognizes it. The only other thing I want you to get out of this, there are other parts of the virus, but the thing in the virus that makes it a disease is the single strand of RNA that's hidden away on the inside of this virus. The only thing these spike proteins do is attach to cells in your body. So typically respiratory lung cells, pharynx, that's all they can do. They just attach. They're like fingers. They attach. They can't, I mean, as fingers, you can't digest food. Your fingers can't, make your heart beat. They can't do anything except what fingers do. And the only thing these things can do is attach to cells. All the damage is done by that piece of RNA on the inside. Okay, with that in mind, I want to go over a little bit about vaccines, just some general comments, because this has been an exciting age with COVID. The first thing is there are two major ways vaccines are made to viruses. The traditional, which is the way that influenza vaccine and most other vaccines are made. In its broadest terms, what you do is you incubate eggs, or now we do it through protein sciences, but you grow a whole bunch of virus. Just imagine buckets and buckets of microscopic organisms. So you grow a lot of virus, and after you grow it, the next thing you do is you kill it. And you kill it with chemical baths, so you dump it in formaldehyde, and then you take it out, you dump it in Clorox. I mean, you kill it several times chemically, and each different manufacturer uses something a little bit different. But so now we got a whole bunch of virus, and then we got a whole bunch of dead virus. So the next thing you do after you kill the virus is you obliterate it. Picture a microscopic wearing blender where you just chop it up into little pieces. And once you've done that through electrophoresis, you separate the spike proteins, the outside, from the RNA on the inside, and then you throw the RNA away. So you killed it, and then you threw it away. So the only thing in the virus that could cause disease first was killed, and then you threw it away. So the first thing is, if that's all you learn today, you'll know about half of what you need to know about flu vaccine and why people don't want it, to be able to say, well, you can't get flu from the vaccine, and here you can't get COVID from this kind of vaccine because the RNA is the thing that causes the disease, and it was killed and then it was discarded. Okay, so after you do all that, you're left over with just a bunch of dead spike protein, and you gather that up, you put it in a little bit of saline, put it in a needle, and you give it, and that's your vaccine. That's the traditional way. With COVID, we've heard a lot about this new way, supposedly new way of making vaccine. It's called messenger RNA. For this, what you do is you take the genome of the virus, and you identify the part that tells how to make spike protein, and you just sort of cut that out. You separate it from the rest of the genome, you throw it away, and then you copy it. So a messenger RNA vaccine is just a little tiny piece of genetic code wrapped essentially in a lipid sandwich. So it's sort of a fatty layer that protects it and allows it to sort of dissolve and get inside of one of your muscle cells after it's injected. And then what it does is it runs over to the ribosome, which is not part of the nucleus. It's in the cytoplasm of your cells. And the ribosomes are where you make proteins. And what it does, it runs over there and it says, hey, Mr. Ribosome, start making copies of spike proteins for this virus. And then you do, and you make lots and lots of copies of the little orange things we talked about. They migrate out to the inner surface, and then they get out of the cell, and then your immune system sees them, and you start making antibodies to spike protein. What's a couple things about this, the company Moderna has been doing this longer than anybody. They've actually been around since 2000, give or take, 2002, trying to make this technology work. They've actually gone through a lot of trials with other vaccines, but we haven't heard of it before because none of those trials worked. And they didn't work not because there were too many side effects, but when you're making a new drug or a new vaccine, one of the requirements is that it has to be as or more effective than what's already available. And the problem that they kept running into is it was never as effective or more effective, like for flu, than the flu vaccine that we already had. Then along came a couple things. They found a better lipid sandwich to wrap it in. And COVID was new. They tried COVID and all of a sudden it worked. We identified quickly the spike protein segment of the genome. They could synthesize that and we could make it. And the biggest thing that's done, I think this is where we're going to see all vaccines or almost all vaccines go in the future now that we figured out how to do it, because it's much, much faster. Instead of going through all the steps we talked about above, you go right to the end product. You just figure out what the code is for that, making the spike protein or whatever protein you're trying to emulate, and you just wrap it up and inject it, and you're done. And that's why Pfizer and Moderna are going to be, why they were approved months before the next one in line, which would be the traditional one, because it's much, much slower. That's enough for that. Let's keep going. In the phase 1, phase 2 trials, they figured out for both of the Moderna and Pfizer that one dose left you had some immunity, but by giving a second dose 3 to 4 weeks later, that immunity jumped from maybe 60% efficacy, which we'll talk about in a minute, up to 95, 96%. And I actually think once we see this given out in the community, if we use the same efficacy standard, we'll see the number, for reasons that I'll tell you about, jump more like to 98, 99%. And again, you're only making spike proteins, so you could make these from now till forever, and all you're going to have is little tiny proteins that could attach to a cell, and then they can't do anything, and then you get rid of them. So again, cannot cause disease. Okay, when you make a vaccine, what is required by the FDA? Well, it has to meet 2 standards. The first is efficacy. It has to be efficacious more than 50% of the time. And then as you go through this, you get to define, and they have to accept what you're going to use as efficacy. So for this trial, for these, what they defined as efficacious was the ability of the vaccine compared to placebo to prevent symptomatic disease. That was their primary target. We'll look at that in a minute. In addition to being efficacious, it has to be safe. We know from going on almost a century of using vaccines on populations, almost all side effects happen in the first 6 weeks. And in fact, almost all the side effects happen in the first 48 hours. Most of them in the very first day, and even beyond that, most of them in the first 15 minutes. And so really, at the end of 2 days, you're well above 99.5% of all side effects, and it's actually probably much higher than that. So what they require, what the FDA requires, is that you track all safety data for at least 8 weeks in a minimum of 3,000 people. Oops, sorry about that. Jumping all around here. Okay, there we go. Anytime after that, that there are, or even during these trials, if there are problems, they go to VAERS, VAERS, where it's a national database where all potential vaccine side effects are tracked, monitored, and investigated to see if there was something wrong with the vaccine that could have caused it. Right now, when I made this slide, which has now been about 3 weeks ago, there were 13 phase 3 trials underway. They had more than 500,000 participants who had been vaccinated at least 3 months earlier. So that's extended now. So we're well over 500,000 people that are getting, half of whom got vaccine, half got placebo, and they're anywhere from 3 to 8 months into that at this point. All right, for the first two, we're just going to focus on these first two vaccines, the Moderna and the Pfizer, put them together and look at their data because they use the same endpoints. 67,000 participants, half of them got placebo, half got vaccine. The very first marker was how many people that got one or the other ended up with symptomatic COVID. And it turned out in the placebo group, 347 people, in the vaccine group, only 19. In this comparison, the 347 to 19 is where you come up with the 94 to 96% efficacy. So almost all the time, it worked. And this is also why I think that the numbers will get better in the community. Placebo in the communities where this was done, this number should have been 700 to 800 based on the level of penetration of COVID in the prevalence of COVID in the communities at the time they did the study. The vaccine group should be about the same if it worked. So really this should be more like 700 to 19. The implication is that the people that volunteered were probably people a little bit more concerned about their health to begin with. So they were probably better with social distancing and wearing masks and the other things that help. But nonetheless, huge difference. Secondary endpoint for efficacy was how many people got severe COVID or died. In the placebo group, you can see 39 people got severe COVID. One of them died, and only one person did not die, but one person got severe COVID in the vaccine group. So percentage-wise, about the same thing, 95+% effective. Once vaccine research is done, there are two different primary groups in the United States that evaluate it. I'm not going to read it, but these two committees review it. They take weeks to review the information, and then they advise the FDA and the CDC separately. These are filled with people that know a lot about vaccines, but they're not allowed to have any relationship with any vaccine manufacturer, them, first degree, second degree relatives, neighbors. I mean, you know, they're just doing everything they can to take away conflicts of interest. And then at the end of this, they advise the FDA and CDC on whether or not to go forward, what to do differently. We've heard a lot about emergency use authorization in the past year. You can read this slide. I'm just going to tell you that for those of you that have ever been to Disneyland or Disney World, this is the FDA's equivalent of a fast pass. It doesn't allow anybody to skip any steps, but it does allow you to go to the front of the line. And we're going to talk about that in a few minutes again. As we go through, one of the questions I get asked, well, what if we've already had COVID? Should you get vaccinated anyway? With both of these trials, it was one of the exclusion criteria. If you knew you'd had COVID, you couldn't volunteer for the vaccine trial. But at the same time, they randomized people to either vaccine or placebo. They also drew some blood, and one of the things they looked at was COVID antibodies, and they found out in the two trials put together, about 5% of them had already had COVID and just didn't know it. And that fits with what we know about COVID, that give or take 25 to 40% of people are completely asymptomatic and don't know that they've had it. So having done that, they looked at those 5% and they tried to find two other things, sort of a mini study within a study. You know, did they did it improve immunity, and did they have more side effects? And in fact, they had no more side effects, and it appeared to improve their immunity. So based on that, yes, people that have had COVID probably should get vaccinated. Again, currently we don't want to vaccinate in the first 2 weeks after turning positive, but anytime after that is fine. When are you immune? You hit peak immunity with the messenger RNA vaccines about 1 week after the second dose. When we get to the traditional vaccines, and there should be some coming up in the next few months that'll be approved, they're just going to be one shot, and immunity will be about 2 weeks after just that single shot. It is important with these messenger RNA vaccines, keep in mind that you don't hit that peak immunity until a week after that second shot. So the worst possible time to expose yourself and get COVID is in the period of time shortly after you get the first dose, because you're almost there. And then now you get COVID. So it isn't immediate is the important thing there. And you do continue to wear masks, socially distance, and ask others to do the same. Herd immunity, you've heard a lot about. It's really simple. The idea is once we get enough, and this is the only way, the only path really out of this disease. Once we get enough people that are immune to COVID, when someone has COVID and they come up to other persons, if they're immune, they're not going to spread it. It will just eventually hit enough dead ends that the virus will just die out. And this is what happens with most things. There are 2 ways to be vaccinated. You can do it safe and effective way with the vaccine, or you can take your chances with getting the disease and being naturally vaccinated. Of course, if you do that, you have a 1 in 35 chance of either having a long-term serious adverse effect or dying. In the United States, this isn't the rest of the world, and it's one of the places where we're just lucky we live here. We will have enough vaccine really by this fall that everybody that wants a vaccine could get it. And that would put us, by the way, close to that 70 to 75% if we could get everybody to participate. Side effects. So you guys have heard a lot about these. The studies, there's nothing to hide here. For the major side effects, and I know people that I vaccinate several hundred people a year for influenza, and every time I do, I tell them, I hope your arm hurts tonight. I hope you have a low-grade fever. I hope you feel, a little fatigued and myalgias for the next 24 hours, because that means your immune system recognizes this thing. It's attacking it. It's doing exactly what it should do. Well, that happened here too, and actually it probably happens even better than with flu vaccine. For headache, muscle pain, fatigue, pain at the injection site, any one of those, about 2 to 5% of people in the 2 studies, cumulatively 10 to 15%. I can tell you in the first 20 facilities that I oversee that had their vaccine clinics, we were expecting 5% of staff to call in the next day and say, I just can't make it, I'm too tired, I got a fever. And in fact, it was only 6 people in the first 15 buildings total. So it was a lot less than we expected. All of these things disappear in 1 to 2 days. And I will tell you, just again, in all honesty, the side effects after the second dose are much worse than the first. They still only last 1 to 2 days. But hey, excuse me, just 1 second. Sorry. They still only last 1 to 2 days. But so far, there have been no serious side effects noted in any trial. You do need to get the second dose. It should be the same manufacturer, because you don't want to go through all this for 1 to 2 days of a little discomfort. You don't want to give up the extra 30% or so of efficacy from the vaccine that you can get. There have been allergic responses. Most people, not all, but almost all of the people that have had allergic response that have been reported were people that have had allergic responses to some component of vaccines before. It appears to be about 1 in 50 to 100,000 people vaccinated, no deaths, 100% have responded and quickly recovered within 1 to 2 days, some within just 30 to 60 minutes. It has no relationship to food or other medication allergies. So pan-allergic or people with other food and peanut allergies are no higher risk than any other person going in. So with that, it is worth monitoring people 20 to 30 minutes after vaccine just to look for those allergic responses, which almost all happen in that short time period. Can you get COVID after a vaccine? Well, yes and no. I mean, it wasn't 100% effective. So yeah, it is possible you could get COVID. What's more likely is that people will be exposed to COVID shortly before or shortly after they get their first dose, and will get COVID 2 days later, 3 days, a week later, blame it on the vaccine. At least you guys know now the vaccine can't cause it. The other thing is the vaccine only protects you from COVID. If people get their COVID vaccine and an hour or a day later have a stroke or a heart attack or a fall and fracture their hip, it is absolutely just coincidence. It'll still be investigated, but I mean, those things happen. We can't stop those with anything else, and COVID vaccine isn't going to stop those either. Other real quick questions, and then I'll take your questions. How was it developed so quickly? I get asked that a lot. It turns out it really wasn't. I already told you, first of all, that Moderna has been around for almost 20 years. So a lot of the messenger RNA technology was already there. So that part, it just worked better. But the other thing that happened, the whole world all of a sudden was working on this. Usually for a new virus, it takes anywhere from 3 to 6 months to just figure out the whole genome. And this one took about 6 weeks. So there's a big head start there. The second thing is the EUA. We normally don't give emergency use authorization for vaccines, but we did here, which just meant every time, whether it was a PCR test or an antigen test or a drug or vaccine, if it had to do with COVID and it went to the FDA, it immediately went to the front of the line. And for drugs, this sometimes takes 18 months or more to get your drug up to the front of the line, get things reviewed and get it through. So this was probably the biggest factor in getting this vaccine done quickly. And then the final thing is this is the first vaccine ever that governments around the world, especially our government, put in money ahead of time. They bought the vaccine before the research even got underway. They said, okay, you've got a good vaccine candidate, start manufacturing it now as if it had already been approved, and we'll pay you for it. And that way, if you do 6 to 8 months of research and then it's a dud, you can throw it all away and you didn't lose anything. And we lost whatever money, $100 million or whatever we put into you making your vaccine, but at least it was a try. And luckily, the vaccines that we invested in are working. They're working really well, which is why as soon as the vaccine was approved, all of a sudden it was available. And that's what we're getting now, is that vaccine. Okay, quickly, is it going to be mandatory? No, but you can get, like we talked about, you can either do the safe way to get the vaccine, or you can do it the hard way and get exposed out in the community and live through the disease, hopefully live through the disease. Incentives, yeah, there should be incentives. Number one, staff. You guys are 1B, 1A, wherever you fit. You got another one of those fast pass things. You get to move to the front of the line. Take advantage of it. It is my understanding that if people sit back and are nervous and want to wait to see their friends get vaccinated first, and you give up your place in line as a 1A or 1B candidate, well, all of a sudden you don't get to just later just sign up with the 2s or the 3s, you have to wait until the general population. And I could be wrong about that in Colorado, but that was my last understanding. The other reason to get vaccinated, even if you don't care about you, care about the people you work with, your family, your kids, your parents. You may be one of those asymptomatic carriers that gives it to somebody else that isn't quite so lucky and has complications or dies, and you don't want that. Pregnant women is a tough question. I think it's an easy question, but on the regulatory side, it's tough because it wasn't specifically studied. There were a lot of women that didn't know they were pregnant, got in the study, went through. It was about 2%, I think, of the patients studied. There were no miscarriages, no extra side effects, and it worked. The reason I think pregnant women should be right at the top of the list is that infant, their only immune system is in utero, is whatever the mom has. And after the baby's born for about 18 months, their immune system isn't mature. It takes that long. So their only immunity is coming through breast milk. So if the mom isn't vaccinated, they're at really high risk because if they get exposed to COVID, they don't have an immune system that will fight it. Can you quit wearing masks? Simple answer is no. Some of the phase 4 trials, one of the questions they're going to try to answer is if I'm completely immunized and now I'm exposed a week later, a month later, can I pass, before my immune system completely kicks it out, can I expose somebody else? We're going to try to answer that. But for that, the main answer is you need to keep social distancing and wearing a mask even after vaccinating. Kids are right now we only vaccinate down to age 16. There are trials now, just now starting, looking at kids down to age 12. This summer, they'll expand that down to kids age 5. Seniors and nursing home patients in these first 2 trials, there were just over 12,000 people over age 65 enrolled. Efficacy was 94%, and there were no extra side effects. Well, there we go. Racial diversity, about a third of the participants in these 2 trials were from a broad range of ethnic and racial backgrounds. And again, your immune system doesn't know black, white, yellow, brown. It just knows how to work. The efficacy and side effects were the same. Immunity, I'll just quickly say, based on everything I've read, I think probably 18 months to 2 years is going to be where we land for when you're probably going to need boosters. When we talk about that spike protein, when the conformation changes enough, through every virus goes through natural mutation cycles. And when that changes enough, we'll need boosters. Maybe even down the road, it'll just be built in with influenza. So real quickly then, why should you be vaccinated? So how many people in the world have had COVID? This is as of last night, 91 million as of last night. How many people have died from COVID? Right at 2 million. How many people have long-term complications from COVID? 2 million more. Okay, how many people have been vaccinated as of last night? 26 million vaccinations. And how many people have had serious side effects? That would be 0. And how many have died because of the vaccine so far? That would be 0. So the vaccine's effective. The disease kills, causes problems. It's safe. You can't possibly get COVID, and there are no GPS trackers. So with that, I'm going to stop sharing. And actually, because I got a pretty urgent text here a minute ago, Peter, I'm going to turn this over to you for a minute to answer some logistical questions, and then I will be right back with you to take on the other questions in the chat. Thank you.
Great, thanks, Dr. Gahm. Yeah, I'm happy to answer any questions about how this is being rolled out. Any questions you may have about pharmacy contacts, anything like that for the group.
Peter, thanks for everything you're doing over there at
Absolutely.
CDPHE. We appreciate it. Have you had any, it's purely a curiosity question. I don't believe I've heard anything one way or the other. Have you heard anything about any of the providers, the pharmacies, the Walgreens and whoever running out of the vaccine, or do they seem to be in pretty good supply at this point?
Yeah, I'm not concerned about the number of doses of the vaccine. The federal partnership program, which is how we got paired with CVS and Walgreens in the first place, took a really good count, overestimated, and so they're going to be able to fulfill all 3 of those clinics that they're going to offer for each facility. There's while well, sorry, I'm trying to talk to you and read the chat at the same time.
That's okay.
Clearly can't
All
do
right.
both. While we may not have all of those vaccines sitting in a stockpile right now, there is a release plan to make sure that all of our long-term care facilities get the vaccinations that they need. And I think, unfortunately, which I think is part of the reason why we're doing this, there is definitely stock because of the number of people who are refusing.
I was going to ask you if you're getting some some reports back of facility administrators, owners, staff, residents refusing the vaccine. So it sounds like that's a yes.
Yes, the early results are that residents are really doing a good job of accepting the vaccine, and but staff are not doing quite as well.
Yeah, I would say I'm back. I would say that's true. We are. It is a sad comment that we're running probably 70 to 75% of residents. We've had some facilities up high 90s in residents, and staff 50%. And a lot of them, it's really interesting. A lot of them, you can give them the data that we just shared, that we've vaccinated 26 people and not seeing anything, and they don't like that. But if you vaccinate the 5 people that they work with and none of them have problems, then they believe it. We have another maybe 10 to 15% of staff that refused it on the first clinic, that all of a sudden now in the second clinic, they're ready. They saw that none of their friends died.
Wow.
And so, yeah.
Peter, do you one more, Peter, and then I'll get quiet here. Do you know if there's any discussion with the governor or CDPHE to make this mandatory for staff?
There has been no discussions to my knowledge as of yet.
Okay.
If I was guessing, and that would be what this is, it won't be mandatory for the first round of vaccine, but as we get further along into, maybe the fall or the winter, or potentially even next year, you look to kind of go the route that we go with the flu shot with it, which is mandated percentage of a facility staff, and do that. But
Gotcha.
I think we're still in so early days that those discussions aren't being had yet.
Okay. Thank you, guys.
Dr. Gahm,
Yes.
I'm going to highlight some of the questions in the chat, if that's okay. One question was about the people are worried about DNA technology and that it may be carried in utero and cause fertility issues or affect unborn babies. Can you comment on that?
Yeah, so the first thing is what's really cool about this, because it doesn't go to the nucleus. It never gets near your DNA. It only goes to the ribosome, which is one of those little inclusion bodies in the cytoplasm. So it never gets near your DNA. And it's not new technology. So this has been going on, like I said, for 20 years. And if I had to do a ballpark figure, I'd say 25 to 30,000 people in the past 20 years have gotten messenger RNA vaccines for other viral diseases. And they're not growing extra limbs and having abnormal kids and all the things, it's not the apocalypse. So I guess the real answer is it's a short segment of RNA that only tells it how to make, this fingerprint, this spike protein, and it's not going anywhere near DNA. So yeah, it's scary because it's new. And especially if you're not in science and you don't understand the technology, all those things are really there. It's a legitimate thing to be scared about. But I would tell you that that is the kind of thing I do. And there isn't a theoretical way for it to happen. The whole thing with the sterile women, all that was started by an obstetrician who happened to be on Oprah's show.
Oh my gosh.
Had nothing to do with she wasn't a part of any of the trials. She didn't have access to any of the data that everybody looked at the FDA. It's part of the anti-vax thing, and there's just no. I mean, the data was real clear. There's no sterility. The whole pregnancy thing, that's fear. I mean, a legal fear. The worst thing you can do is hurt an unborn baby, because the way that awards are handed out, it's lifetime earning potential. So it's the scariest group, but it's also, like I was telling you, it is the group most needing to be protected. If my wife is pregnant, or one of you pregnant, you got to be worried about COVID. I mean, the potential complications from the fever or the disease to the mom, the baby, they're real. And they're scary. Not the vaccine.
And Dr. Gahm, if I may, you just to top that off a little bit, you've not heard of any reports of it causing infertility of women?
That would be actually
substantiated reports.
Yeah, in the way they defined it, that would be considered a major or a serious side effect. So right now, 500,000 people into it, nothing yet. Yeah.
Gotcha.
There's very few things that are perfect. I did see a question, why is the second dose worse? The second dose is worse than the first because your immune system works. And if it works and you've just, given it spike protein and said, if you see this again, go attack it. And now 3 or 4 weeks later, you give some more. Your immune system says, I know what to do, attack. And you've got neutralizing antibodies everywhere. And so you attack it and symptoms are worse. But it just is a sign that your immune system is doing exactly what it should do.
So it was 2 more, I think, questions. One is related to if somebody gets COVID in between doses, they should go ahead and get the second dose, correct?
Yeah, I mean, that's a tough question. I would say yes. I mean, it isn't. I mean, to some extent, you don't need it because you got the real thing and you're seeing it and you're doing whatever you can. But just the fact that in the trials, the immunity was a little better after the vaccine than it was even for those people that had already had it, I would say, sure, go ahead and get the second dose.
And then what about the conventional vaccine? And I think you kind of addressed this, but maybe just briefly, in the way the vaccine is formatted, why that one only requires 1 shot and these require 2.
Just, when you're looking for that efficacy standard where you have to be better than 50, with the messenger RNA, my understanding is after the first round, they were in the 60 to 65% range, which is actually pretty good. That's where we land every year with flu vaccine. And the CDC keeps telling us that's really good. But when they challenged and they gave the other one, it jumped from 60 to 65 to 95, 96. With the single dose, made the traditional way, their first round is up in the mid 70s to high 80s. So, the idea of giving a second shot to increase it by 5 or 10 points doesn't make sense. But if you could move it by 30 points, it does. So there just wasn't that much improvement. And we'll see, I mean, we haven't seen all the final data on the traditional vaccine. We just have preliminary reports that put it in that 75 to 90% range. They may actually be better too. I don't know.
And then there are a lot of people who are asking for copies of your slides so that they can share it with their staff and make the push for compliance with vaccinations. So I'm not sure if I have your right email to use for that, or how would you like that to happen?
I'll send that to you. I actually tried to send it out earlier today, and it was like at 25.2 megabytes. So it was like 0.2 of a megabyte larger than what I could send. So I may have to trim something out of it, but I'll send it to you.
Peter Brissett, can we put that on the CALA website for people to download if they want?
Of course.
Okay, that'd be good. Yeah, if you want to just email it to Peter, Greg, that would be great.
Sure, Peter, what is your, I'll just do it right now. What is your email address? I may have it somewhere, but.
Yeah, we've emailed, but I'll type it in the chat.
Oh, okay, great.
Any other questions for Dr. Gahm or for Peter Myers from anybody? I think this has been really helpful.
There was the other question from Maggie about if you get the vaccine and you have quote unquote some kind of symptoms, your body's doing that. Do you have to quarantine?
No, and those symptoms, the other thing, if you're really worried about, if you consider yourself a really allergic person and you just react to everything, you can always take an antihistamine ahead of time. You could take, Allegra or, pick your favorite, whatever it is. It won't affect the vaccine, but it will block any histaminic response that you might have.
The other thing I'll do to you guys is I've made a copy of this recording. We'll post this all with the slides and everything on the website, so you can just share this with your staff. So Maggie's got another question. If you got your two doses within 90 days after the last dose, and you go to Mexico for vacation and return without having to quarantine on your return.
Should you have to quarantine? Well, if you ask me, the answer is no. And probably these days, most states in the US are worse than most countries around the world. I don't know about Mexico. I don't know, Peter, have you looked at Mexico lately? I just think it's bad enough here that you could stay at home and have the same question.
I have not spent a lot of time looking at Mexico, although I am extremely jealous of the question because I'm assuming someone has some plans.
Yeah.
But I think I'll speak to the larger kind of point of the question, which is seeming to get at, as we move through the vaccine and we have guidance about quarantine, about exposure and moving into your home, moving into your residences, I would expect that guidance will continue to evolve as the vaccine is rolled out. It is not currently. I'll just make the plug for, as you're getting your vaccine and working through your first dose, continue to mask and social distance and follow all the guidance that CDPHE has out there. We're going to be, I think, in lockstep with the CDC as they come up with new guidance as we kind of move away from this public health emergency into what we're hoping is a safer state with the vaccine. And I think that goes for testing as well, Mary. We're going to continue to test here, sitting here as of January 12th. But we're going to be looking, hopefully, as people get vaccinated and things change, to roll some of those things back.
There's questions going on in the chat that Dr. Gahm is answering about Tylenol, ibuprofen, or Motrin. For those of you who can't read the chat, and those are acceptable to use to minimize symptoms. but they should go away in 12 to 48 hours.
And the question, the best answer I can get about testing and continuing is I think we're all waiting. I mean, we're all throughout this, we're waiting for leadership. And in that regard, I don't think many states are going to be willing to step out and just say, we're going to do this on our own and say, you're vaccinated, you shouldn't be tested. At that point, I would. But I think we're waiting for CMS, FDA to say, yeah, it doesn't make sense to test people once they hit their immunity peak. But who knows? It's a bureaucracy. And right now it's a bureaucracy in transition, which makes it even worse because we're going to go from the hoax side of the equation to the, apocalypse side of the equation. So somewhere in the middle, we got to find common sense.
Yeah, and I see Vicky's comment in there. If you haven't heard from your federal partner yet, CVS, if you chose CVS, you should have heard from CVS already. They have scheduled all of their clinics. So if you chose CVS and you have not heard from them, you can reach out to CVS. I'll put my email in the chat as well. You can send me an email. Walgreens, I believe, was still finishing up scheduling just a number of clinics. So it's possible that if you decided to pair with Walgreens, they could be calling you shortly. But I would say if you paired with either one of them, reach out today and ask some questions. And I'll put my email. We can help facilitate that conversation as well.
So I'm going to join you in here, if you're okay with that. Or
Peter, there was a few more questions. Did you see those?
Sorry,
Yeah.
no, please stay here, please. I'm going to log off this in just a minute.
And I see one from Vicky. If you haven't signed up or have not heard from a federal partner, yes, please contact us. If you didn't sign up, we at CDPHE actually went through and tried to match any facilities that didn't sign up through the federal partnership with a pharmacy. So we had 100% of our facilities that were either matched with the pharmacy or potentially looking to get immunized by state response teams.
And what happens if your facility, only some of your staff or residents agree to the vaccine and the others do not? How does that affect the efficacy?
It doesn't affect the efficacy in those that got it.
Right, but as in a whole, community as a whole.
Yeah, it's, for the herd immunity, sure, you'd like, your staff are the people you spend most of your time around. You'd love to have a high degree of them vaccinated. But the reality is you're also at work, you're more likely to be wearing a mask, social distancing, remembering all those things. It's when you go home and invite siblings over and they look healthy and you think, well, why wear a mask? It's my brother, my sister, my parents, they don't look sick. And then you take your mask off, you don't socially distance. And before you know it, you're positive because they were positive because they went to the grocery store without a mask, or who knows. But it's out in the community where you'd really like to see it, which means that we're looking at late summer. If everybody got on board, late summer, we could have 150 million Americans vaccinated, but probably not going to get there because there's just too many myths and misperceptions.
So maybe you can tell them what you told me, the presentation I went to, that if we did get herd immunity at 70 to 80%, we might be able to move forward come fall. If not, at 50% or so, we might be looking at having to live with life as is for the next couple years. And if that doesn't incentivize your staff, I don't know what will.
And in fact, continuing masks and social distancing But also the longer it takes, the more likely we are to get to enough of a mutation that we will need boosters. You know, and now we're going to have not only your vaccine, but your vaccine booster next round before we can get there. You know, the best way to shut this down is to get as many people vaccinated quick to try to shut it down before we give the virus opportunity to continue at the rate it is and to mutate in new strains.
Dr. Gahm, forgive me. I know you already said this. So I've got 2 sons that have had it. They're over it. They're past it. They should or should not get the vaccine.
How old are they?
They're both early to mid 20s.
And they should. Yeah, and so if this were my family, what I would tell them, wait 90 to 180 days. At their age, you know, they could wait a year. For you and I, you're over 50, let's say.
Mm-hmm.
You know, for a virus like this and the vaccine that goes with it, right after the vaccine's over, you peak pretty quickly, and then you start to drop off. And we know for influenza, for instance, if you're over 75, at 3 months, a quarter of people are no longer immune that did have immunity to begin with. So the older you are, the faster it goes away. If you just had COVID 3 weeks ago, your immune system is pretty geared up and seeing it. If you wait till this summer, it'll be more like a booster because some of your immunity has started to wane, and then you get your shot and it'll jump it right back up. I don't know. That's fine tuning your immune system. I think the answer to your question is yes.
Yes. Gotcha. Thank you.
Okay. And I think Peter signed off, and I think he's signing into the next meeting where we're both headed. So thank you, Tammy, and Peter for having us.
Thank you so much for your presentation and answering all the questions and answers. I think you guys are good to go. I think Blake, if he's still on, might be able to answer the one question about workman's comp.
And let me just say for Maggie and anybody else, I'm easy to find and easy to get to. If you send things to Peter or to Tammy, they can get questions to me. I'm pretty good about answering emails. I'll get answers back.
Thank you again.
Okay,
thank you guys.
Thanks, Deb.
Tammy, I'm still here. What was the work comp question? I can't see it in the chat.
Yeah, the question was if one of your staff, it was from Rachel. If one of your staff.
I can reiterate it, Tammy. Hi,
No,
Peter. So I had a question. You know, if we have something like a staff who got the vaccine under our business or through with, what would that mean for us in the business? Would we have to file a workman's comp? I mean, have you heard anything in that? I mean, if there were any complications with these vaccines that have been given to any of these people in their businesses?
Yeah, through the businesses, it would be covered under workers' comp.
Okay.
So
and the residents would be probably under their own insurance or through their.
Correct. Yeah, this would not be covered under entities workers' comp, just the employers or employees.
Okay.
Yep.
Is there any other questions? I just reviewed the chat and I don't see any other questions that I think we've missed. If we've missed anything at all, please email them to us at Kala, and we can make sure to get answers either from Peter Myers or from the doc. I know I personally believe this was a great session. I think we're off to such an exciting start to vaccinations and getting some answers in regards to COVID. And I just want to say thank you again to everyone for